was a workshop about compliance. And as you see, I changed the title. I went for adherence to treatment and not compliance for treatment. So why? Because there are some different definitions of what is compliance and what is adherence. If you talk about adherence, that the definition is the extent to which a person's behavior taking medication, following a diet, and or executing lifestyle changes corresponds with agreed recommendations from a healthcare provider. So the little word agreed is very important because the agreement of the patient differentiates the adherence from compliance. Adherence requires the patient's agreement to the recommendations, whereas compliance does not. And if you really want that your patient take the medicines you prescribe, you need, at the first step, agreement. If there's no agreement, there's no idea and no possibility to have your prescriptions followed. So the definition that was the definition of the World Health Organization I gave you. We have another definition from the European Unions. So this one is a little bit more detailed, but it's the same, about the same thing, about adherence. It's a process by which patients take their medication as prescribed, composed of initiation, implementation, and discontinuation. Initiation occurs when the patient takes the first dose of a prescribed medication. Implementation is the extent to which a patient's actual dosing corresponds to the prescribed dosing regimen, from initiation to until the last dose, and persistence is the length of time between initiation and the last dose, which immediately precedes discontinuation. So if you take this definition of adherence to medication, the patient is starting the medication, he is doing exactly what is written on your prescription, and he is persisting during time. My first question for you were, in your opinion, what is the rate of adherence to medication by a newly diagnosed patient with GIA, a child, parents are giving a treatment, and in adolescents with lupus? Studies are showing that even if you explain everything well to the parents, adherence is about 52% only in newly diagnosed GIA patients and slightly higher in lupus patients, adolescent lupus patients. And what is interesting to know that it is, even in children, it's barely higher than in adult patients. In adult patients, you have about 50% of adherence for all chronic diseases, if you take them all together. And in children, it's just slightly higher, not so much. So parents are doing exactly the same thing with their children that they would do with themselves. That's one of the lessons I learned from adherence studies. So, and even if you go to other things than just medication, that is in a European context, in your opinion, what is the rate of adherence to exercise recommendations by newly diagnosed children with juvenile GIA? You say that they have to move, they have still to move, they have to go to school, they have to move, they have to do sports activity. How much, to how extent parents are doing that? In the European context, it's 35%, so it's very, very low. So even if you prescribe physiotherapy, they don't go to the physiotherapist. So I tried to have 2 clinical cases to work on them, to see how we could change and how we could assess adherence to treatment. So Aaron is a 15-year-old boy. He is coming to my outpatient clinic and he is addressed for initiation of an IL-1 inhibitor. His history is that he has been diagnosed with FMF at the age of 2 years. The diagnosis is clear. He has 2 clear mutations. He took colchicine since diagnosis, and he needed a gradual dose increase to 2.5 milligram per day. The mother says that there is a good adherence to medication, and the child, the young boy, says that there is good adherence to medications. The mother even adds that she is managing the stocks of the medication, and she goes to the pharmacy every month, and she is buying the medication her son needs to have 2.5 milligram per day, and she gives the medication. So they are really very clear on it. Adherence is good, so we need another treatment for FMF. If you take history further, you see that he had a rather good control of the disease during childhood, even if he needed high doses of colchicine. It's a sports patient. He loves football with friends. He's not doing the game in a club, but he's almost playing daily with friends, and he's doing weight training at home. The recent history is that he has a sudden clinical deterioration. I have seen him in October, and since August, he has had at least 20 inflammatory attacks. He was basically ill all the time since August, with fever, with transfixing chest pain. And the inflammatory excesses followed always sports training. On the clinical examination, he had fatigue, pain on deep inspiration. Otherwise, the clinical examinations was clear, and he has raised inflammatory markers. We did a little bit of checkup to see if there are no other diseases in this child, in this young boy. There was nothing else than FMF. So there's no discussion about another comorbidity, for instance. It was just FMF. If you go to the social and family context, the parents were divorced since 2 years, and Aaron lives 1 week out of 2 at his father's house. So he's 1 week with his mother, 1 week with his father. He has one younger sister. He's a very bright student. He's well integrated in a group of friends. But the only thing I might find in the history taking is that the paternal grandmother died 5 years ago from renal failure. It's not really clear why. This lady also had FMF, and it's not clear if she had secondary amyloidosis or if she died from colchicine toxicity. It was not so clear at the first history taking. So, if you go for the EULAR, recommendations for the management of FMF, you have to assess compliance before prescribing EL1 inhibitors. And that is what I want you to do. So, what would be the determinants of possible therapeutic non-adherence in this patient? So, indeed, there is more than possibly one reason. The fault we are often doing is that adherence is has only one determinant, and it's only the patient-related factors. And you are right, they are not only patient-related factors, it's just one determinant of others for adherence. So the common belief that the patients are solely responsible for taking their treatment is misleading, and we have to look where we can have an action on it. So there are 5 dimensions of adherence. There are social economic factors. You told about it. It is a house. He's living, his parents are divorced. He is living not as before in only one house. There are therapy-related factors. That's the colchicine toxicity. That's the death of his grandmother. There are patient-related factors. He is adolescent, and he's probably a little bit rebellious, as you say. But there are also condition-related factors. We will speak about it. And there are healthcare team-associated factors that we have to assess also in this patient. So if we go to the social and economic factors, there are long lists. There are long lists of social and economic factors who has been proven to be associated to non-adherence in patients. The first one is the poor socioeconomic status, low level of education, and lack of effective social support networks. Probably in this patient, that is not a problem, but unstable living conditions are a factor of non-adherence, and this patient has an unstable living condition probably. Changing environmental situation culture and lay beliefs about illness and treatment are very important, and I think it's very important to assess this. If you have, especially if you have patients from another context than the dominant culture in your country. Family dysfunction is also a factor that goes to non-adherence. High costs of transport if the hospital is too far away from where the patients are living, if there is no health insurance and so on, that are all factors, social and economic factors for non-adherence. For Aaron, he lives in 2 houses, you told it. And as in all adolescents, self-esteem, body image, social role definition, and peer-related issues are probably more important than adherence to treatment. So that's really one of the big reasons in all adolescents. And the rebellion against the regimen's control over his life, probably also. His mother is still controlling everything, or she tries to control everything, and she's not able to do. So we have to assess what we have to assess is if the mother buys the medication, is Aaron really taking the medication? You can buy something but not take it. You can do it in the dustbin. In this patient, it was really what happened, so he didn't take it. So we have to need to explore lay beliefs about illness and treatment. We don't know what he is thinking about colchicine and what he is thinking about the disease. You told also about it. And we have to assess the family dysfunction. So that's one of the determinants of adherence. The second one is the therapy-related factors. And there's something very important. We need to know, especially in our lupus patients, if the medical regimen is too complex, patients does not take everything. They pick some of the treatment out of our prescription, maybe just the red pill or just the blue pill, I don't know, but not the other ones. So probably we have to pay attention that our prescriptions are very, very simple, and it's easier to take 1 or 2 medications on a prescription than 5. So that's not a problem for FMF, but that may be in more complex diseases if our prescriptions are too complex. The duration of treatment is also a marker of non-adherence. If patients have to take treatment for a long time, they don't remember that it's important to take it and they stop it. Previous treatment failures, frequent changes in treatment are also determinants. The immediacy of beneficial effects are very important for adolescents. An adolescent needs to see what the medication is doing. If he has not an immediate effect of it, he will stop taking it. Side effects that we have to explore with Aaron, and the availability of medical support to deal with them is also an important factor. So for Aaron, we have probably duration of treatment, side effects, current for him, and feared with the beliefs of the death of the grandmother that needs to be assessed. Because if he is sure that his grandmother died from colchicine, he will stop this treatment, that's sure. So patient-related factors are about the knowledge, about the motivation to manage illness, and about his confidence in the ability to engage in illness management. So the self-efficacy is really what we can say, yes, I can, I'm able to do so. And we are not sure that Aaron had this self-efficacy because his mother was doing the treatment for him. So we have no information on this item, but that needs to be assessed. The motivation and self-efficacy may be low as his mother is still managing treatment, administration, and the worries about dependence is a classical factor for low adherence in adolescents. Adolescents fear that if they take the medication now, they could never stop it. So they try to stop it to prove that they can live without the medication. So that's really an important determinant. So we have to explain our adolescents that they take the medication because they will be in good health with the medication, not without. As we take some glasses on if we don't see, we have to take medications if we are ill. That's what I am saying them. The condition-related factors are also important. The severity of symptoms and the level of disability if the level of disability is higher, the adherence goes down because they don't see the efficacy of the treatment. If you are very disabled, taking medication, you say, yo, there's no change if I take the medication. So probably we have to assess this specifically, we have to tell them that it would be worse if they don't take the medication. And then the comorbidities have to be assessed with depression and alcohol and drug abuse that we don't know in Aaron, and his risk perception and priority of adherence is probably low. And something we're always forgetting is this one, the healthcare-related factors. Healthcare team factors may be more important than sociodemographic variables. If you go to the studies, you see that healthcare-related factors have a higher impact on adherence than sociodemographic variables. So the good patient-provider relationship is very, very important, especially in adolescence. And we, as pediatricians, if we have followed up the children since the age of 2, sometimes we fail to have a relationship with the child and not with only the parents. So we have to work on that. And we should not have the same role as the parents. A doctor shouting on adolescents is not effective for adherence. So we have really to ask ourselves how to manage adolescent patients. So factors with proven negative effect, that's in studies you can find that is overworked healthcare providers, lack of feedback on performance. You have to say to the children, yeah, wow, you are good on this, but you are able to do better, not to say, no, you are not good, you have to do better. It's not the same thing to say you are good, but you have to do better, or to say you are bad and you have to do better. Short consultations are also a negative effect for adherence. The inability to establish community support and self-management capacity, and the lack of knowledge in physicians on adherence and on effective interventions for improving adherence. So we have to really pay attention about this. If we know about adherence, patients will take better their medications. So Aaron, we decided that he was not resistant to colchicine, that it was only a problem of adherence, so he joined an educational program for adherence, and here you can see the CRP levels who are going down on the years. We needed 2 years to be him fully adherent to colchicine, but we managed to do so with an educational program. So even if the mother told us, and he told us that adherence was good, after an educational program, he really had good adherence. So if you look for tools for adherence assessment in clinical practice, there are some clinical practice tools for adherence assessment. The best known is the Morisky self-administered questionnaire, but you have other possibilities to do so. So what is the Morisky medication adherence scale? It's a scale of 8 questions. You give for a good answer, if adherence is good, for every question you give 1. And if the adherence is bad, you give 0. So you have to ask 8 questions to your patients. The first one is, do you sometimes forget to take your tablets for instance, lupus? If the patient is saying, yes, I sometimes forget, you will give 0 to this item. If he says no, you will give 1 to this item. The second question is, sometimes people don't take their medication for reasons other than forgetfulness. Thinking about the last 2 weeks, were there any days when you did not take your medication for lupus? If he says yes, it's 0. If you say no, it's 1. Okay? You did understand the principle of this? And you go on. Have you ever reduced the dose or stopping taking your medication for lupus without telling your doctor because you felt worse while taking it? Again, the same system of rating. When you travel or leave home, do you sometimes forget to take your medication for lupus? Did you take your medication for lupus yesterday? Yes, no. When you are feeling much less, if not more at all, your symptoms, do you sometimes stop taking your medication? Again, if he says yes, it's 0. If he says no, it's 1. Having to take medication for lupus every day is a real inconvenience for some people. Do you ever get upset about having to take medication for lupus? Again, the same system, 1, 2, 0, 1. Do you ever have had trouble remembering to take all your medications for lupus? Never 1, rarely 0.75, and so on. And then you make the sum of all your points. If the patient has more than 7 out of 8, you are sure there is good adherence. If he has more than 6, there is fair adherence, and he is less than 6, it's poor adherence. So it's an easy tool. You can do it in the waiting room with your patient. So we are not you should not need it to do it during the consultation, but you can have it at the beginning of your consultation. The problem is that school-age children and teens, exactly like adults, they exaggerate their adherence behaviors in their self-reports. If you do it too often, the more risky. They know what you are waiting for, and then they will answer how they think that you want to have to answer them. So that's the problem of this tool, but you cannot use it sometimes. If you have patients who are you really not sure, you use it once. So in daily clinical practice, what we can do during the outpatient visit is to explore with the patients and the parents the perceived barriers to treatment. You ask them, what, in your opinion, is what will be difficult for you in your daily life to think about your treatment every day? So the most common barriers, for instance, in GIA are the worry about future, the worry about pain, and forgetfulness. So if the parents say, okay, I'm afraid that my child will have difficulties later on in life, you have to know that this is one of the factors of bad adherence. And studies showed that non-adherence increased by approximately 30% with each additional barrier identified. That explains you why in GIA, in newly diagnosed GIA patients, we have an adherence only of 50%. Because all the parents are worried about the future, worried about pain, and worried, probably not all, but at least all are worried about the future and pain in their children. And if there is adding forgetfulness, you have the mean adherence scale of 50% only in newly diagnosed patients. So you have to assess all this and address these things with the parents during the follow-up visit. So if you want to have more structured interviews, as I would try to prepare some questions you are always asking to your parents and patients during your outpatient clinic, to know if there are factors of bad adherence. So I gave you here some possibilities of questions, but I think it's important that you have your own questions in accordance with your how you are working. And you are not. It's not necessary to have all the questions during one outpatient visit. But if you see the patient again, you can mix a little bit up your questions, and you see globally how the patient is managing with adherence. So I ask, for instance, how much do you think your health depends on taking medication? Are you worried about having to take medication? Do you sometimes worry about the long-term effects of your medication? Do you think you would be very sick if you didn't take your medication? How much are medications interfering with your life? Are you afraid of becoming dependent on your medication? How effective do you think your medication are in keeping the disease under control? Is it uncomfortable for you to take medication? Do you think forgetting medications from time to time will affect your long-term health? How do you experience taking medication on a daily basis? Any positive feelings about your treatments? It's important also to ask about positive things. And I often ask them what additional information I can give them on their treatment. And then you see if there are risk factors for non-adherence or not. So it's really a daily thing to do during outpatient clinics. So in some possibilities, you could maybe do measurement of serum drug metabolite levels, but that depends really on the medication. It's possible with some immunosuppressants, but not feasible for most biologicals, for instance. It's not feasible for colchicine. And the problem is that serum level not always are not always predictive of complete adherence to treatment. One dose may be enough to have a positive blood test. So it's not a so good thing for adherence assessment, the measurement of serum drug metabolic levels. And then what's coming here is very modern, the connected devices, but it's only used in clinical studies, and in daily life we don't have connected devices to see if patients are taking medication. In Canada, for instance, it's possible to see if the patient is coming to the pharmacy and is buying the medication. In France, it's not possible. I think it's the only land in the world, country in the world, is Canada, where you can do that. So you know if the patient took what was on the prescription. So just a very short next clinical case, again, an adolescent with systemic GIA. She had GIA at the age of 14. She had a very severe form. She needed high doses of corticosteroids. She was unresponsive to EL1 inhibitors. And we were able to taper very slowly steroids only after EL6 inhibitors. The complete withdrawal of steroids was possible only after 16 months. So at the age of 16, when I see her, she is in clinical and biological remission of GIA. But she complains about diffuse pain and fatigue with impact on daily activities. She has very, very low school attendance. If we, on the physical examination, really there are no clinical nor biological signs of active inflammatory diseases. The joints were unremarkable. She had a great muscle waning. And it was impossible for her to do any physical activity. The Ruffier-Dickinson test is something sportsmen are using to see how fit they are, and you have to do 30 bendings in 45 seconds. So she was totally unable to do this Ruffier-Dickinson test. So the diagnosis was severe physical deconditioning. Nothing else. So it's not a discussion about the diagnosis. We are sure about the diagnosis. So I prescribed her exercise physiotherapy twice a week. And I gave her some tips for resuming physical activity. And I said, okay, we will see again in 3 months. She came back 3 months later. She had exactly identical complaints, fatigue and frequent myalgias, poor school attendance, but she didn't start physiotherapy. So, my question to you, what can you do in this patient? I think there are very good ideas. Indeed, the depression, the associated comorbidities are very important to assess. But even if there are none, the action you will do will depend on the key stage of change. You have to know that if you change, it's a stepwise thing. You go for change, not in one. If you want to go for a change, it's very long processes. So you have to assess, the first thing you have to assess in this girl is on what level she is for change. What is her desire to change? So there are five stages. The first one is pre-contemplation. That depends, no, not me. That doesn't concern me. So you are not interested in change. And that is very difficult. You can prescribe what you want. If the patients are in this stage, pre-contemplation, then you will not succeed in anything you will propose to them. The second stage is contemplation. Well, I'm looking at it, maybe I could change. That's a better one. The third one is planning or determination. That needs, okay, what could I do if I want to change? The fourth one is action. Okay, let's do this. And maintenance is, I've done it and I know it's possible. So that's the key stages of change. The problem is that at every stage you can relapse. You can go back to the beginning. So our therapeutic actions need to be adapted to the stage of change in which stage of change this girl is in her daily life. If she is in pre-contemplation, we need to show the contradictions. We need to show her that she's not so right. We need to raise doubts. How could we do that? We could do that, okay, you complain of muscle, of myalgias, but you don't have any muscles, probably because of the treatment, but because you received corticosteroids. But to have muscles again, you need training. What do you think about that? Muscles will not come back alone. So that's it, show contradictions and raise doubts. If she is in the stage of contemplation, you have to ask her about the advantages and the disadvantages of the statu quo and of the change. And our work will be to tilt the balance towards change. We have to orient her to say, look, you have more advantages to change than to stay as you are today. If she is already at the stage of determination, our work should be to plan a program of action with the patient. So that is the supervised physiotherapy. That's the possibility to go playing better than physiotherapy, to see with her what is the program of action what would be good for her. If she is already in action, it's not the case for Noor here, but you have to support her, that you have to say her that it's very good, even if it's suboptimal, you have to say, okay, you are doing it, it's great. And if she is again already in the maintenance phase, you have to help her to identify relapse prevention strategies. It's very difficult to be in maintenance, so it's our role to say, okay, it's great, you are doing sports now, but in your opinion, what are the dangers that you will stop again? How could you go against these dangers? And if she relapses, we have to return her to a strategy of change by avoiding paralysis and guilt. We are always giving guilt to our patients. We are often giving guilt to them. I think it's very important not to give them guilt and to try to go back to a strategy again of change. So really, that will depend on the stage in which she is about change. So I like very much this phrase. It's one of my professors of diabetology in France I had when I was a student. He said, the chronic patients must accept two things: his finiteness, because his treatment will only end with his death, and his difference from others who are not ill. If you look at this sentence, you understand why it's so difficult to have adolescent patients, because they are sure that they will never die and they want to be exactly as their peers. So that's the problem with our adolescent patients to go for adherence in treatment. If we are able to make them accept this, probably they will be adherent to treatment. So there is a very, very good report of the World Health Organization about adherence. Much of this topic is coming out of this. So it's named Adherence to Long-Term Therapies, Evidence for Action. And it's really, there are really solutions in it for all, also for all the socio-economic context. I think it's not exactly the same on working on adherence in Europe than working on adherence in India. I think the problems are not exactly the same. But in this report, you have really ideas how you could go for better adherence in patients, in all the patients all over the world.
Thank you to the Fondation Rhumatisme en Suisse and to the Pediatric Rheumatology European Society Press for their technical and financial support to create this video.